Thank you very much. I'm aware that any minute now the champagne or whatever reception will break out and everybody will disappear. So I will try and be as brief as possible and try and keep to time. So I've been listening to my disclosures. None of this is particularly relevant to what I'm going to be talking about today. I've been listening this morning, and a number of people have made this point, that there is a deadly synergy between herpes simplex and HIV, that the virus accounts for 30% of transmissions or acquisitions. So it's a major issue, and that's why there's been so much effort in trying to control this virus around the world. So the way I've structured this talk, I'm going to talk about symptoms and signs, variations in natural history, then treatment options, and finally concentrate on the complications, prognosis, and clinical management for those with HIV infection. This morning we did cover the epidemiology. There are a few points that I will make about the epidemiology because they weren't stated up front. Internationally, we appear to have reached peak HSV, and HSV levels appear to be on the decline. So in North America, where we have excellent NHANES data, the rates have plateaued and have started going down, certainly amongst the non-Hispanic white groups. There's a shortage of data in Europe, but there is a study from Germany showing a similar decline in their population. So that anxiety that HSV2 rates, which just continue to climb and climb and climb, it has not come through. The natural history, I'm sure you're aware of this. We start with initial infection. When people get infected, we don't actually know the exact transmission rate. We know that in about 50% of people, there are some cycles of replication in the skin that abort through natural immune processes. They don't establish infection. People will then go either straight into latency, which we think 3/4 of people do without a clinical presentation, only to subsequently become apparent when they reactivate. And 1/4 of patients, of individuals, will get symptomatic first episode disease. We now suspect that there is no one really out there that doesn't reactivate when they're infected. We used to say about 2% won't get a clinical recurrence in a year, but when you look at shedding data, everybody reactivates, and the rate of reactivation is variable. So how does the virus work? Well, as I mentioned, it gets into the skin, it can be directly inoculated into mucosa. Usually, if there are breaks, it'll be easier. Cycles of replication in the skin. The infection gets going in the skin and then it's cleared by immune processes, but during that stage, the nerves get infected and then it sets up latency in the dorsal root ganglion. So an initial infection, typically we see symptoms 4 to 7 days after infection, and usually a classical recurrence, although few people will, initial episode, but few people will actually have a classical first episode. The lesions will be bilateral, starts as erythema, develops rapidly through papules, blisters that then ulcerate. These ulcers are very fragile, they're painful, and when you scratch at them or you abrade them with the swab, they bleed, unlike the ulcers that Ned show you, which tend to be clean and only ooze sera. They're not indurated, which means that when you try and pick them up, they come up with the skin. There's nothing under the skin. They're associated with local lymphadenopathy, and there's some mild systemic symptoms, usually of myalgia and headache. Now, usually symptoms peak at 11 days, and then they should be over by 3 weeks. But there are a few individuals who will have episodes that last up to 6 weeks. They tend to be associated with a worse prognosis. Now, clearance from the skin requires an intact functioning immune system. And if your immune system is shot to bits, then and your cell-mediated immunity in particular, then you will not clear quickly. Recurrences, we now think that they are very frequent. The virus travels down the nerve, tries to come out of the neuronal dermal junction. There's an attempt to replicate the skin. We know that most of those attempts are blocked, but that a few will escape. There will be some replication. The lesions that form may be microscopic. The patient may not notice them, and they will then get shedding. The range of recurrent disease is highly variable. They can be very atypical, or you can have the classicals, papule, blister, ulcer stage. And then a lot of these recurrences, there'll be nothing at all. There'll be just virus on the skin, and the patient will be infectious, but there'll be no symptoms. Now, recurrences, how frequent are they? Well, the data for all of this really comes out of the Seattle group, and they've been refining their studies. They've been swabbing, getting patients to swab every day. This is one patient who swabbed every day for up to 90 days in this study. And they kept diaries and were intermittently examined just to check that their diaries and their, what they looked like was similar. So these are days when the patient had lesions at the bottom here. These vertical bars show you how much virus was present, and you can see that there's high levels of virus when they have lesions, but there's also high levels of virus on other days, and this is asymptomatic shedding. Now, you can divide asymptomatic shedding into extended periods and these isolated short episodes, and these are important because when it comes to therapy, we can control these episodes, but we don't appear to be able to control the short episodes. So asymptomatic shedding is frequent. So, as I mentioned, the majority of recurrences are atypical or asymptomatic. They're short-lived. Occasionally, there's a warning of a prodrome. But if it's going to come through, there tends to be a rapid evolution from erythema, papule to blister ulcer. And this stage is usually about 24 hours. So if you're going to try and intervene with therapy, it has to be very, very quick. Once you've gone beyond the papule stage, therapy seems to make very little difference. Lesions tend to be confined. They're short-lived, they heal quickly, usually without scarring, and occasionally a patient will report systemic features. Now, when patients get HSV1 or HSV2, the pattern tends to be different depending on where you're talking about. On the genitals, HSV2 will recur much more frequently than HSV1. The typical pattern is 4 to 6 episodes a year, but 10% of patients will have more than 10 episodes. With HSV1, you'll typically get 1 episode in the first year and then an episode every 18 months thereafter. Now, recurrences. As I mentioned, the Seattle data suggests that people recur a lot and they have short episodes of shedding quite a bit. Recently, they've actually extended their work to doing biopsies, and they biopsy the skin as well as take skin swabs. And what these biopsy studies show is that actually often when the virus comes down, it just gets blocked in the skin, and it doesn't actually replicate. It just causes inflammation, and that is actually 2 or 3 times more likely to do that than shed. So the actual number of days on which the virus comes down the nerve seems to be quite a lot compared to our previous thoughts on this. And it may be 2 or 3-fold what we previously thought. So I'm now going to move on to HIV Hsv Co-Infection. When you get this situation, the recurrence rate, certainly from swabbing studies, suggests that it's much more frequent. And this is one reported in predominantly MSM men, but in MSMs. But similar studies have been done in pregnant women, and these show that there's up to 300% more shedding from the skin. And that's because the immune system that blocks the virus as it tries to get through the dermal layers is just absent, I think, in these situations. Also, in follow-up studies, people with co-infection tend to have multiple site involvement at the same time, and that when the immune system is weak, the absence of effective cell-mediated responses leads to persistent active disease, and I'll show you some pictures of these. As I mentioned, these studies have been repeated in other groups. There are studies in pregnant women which also show very high rates of shedding and activity. So with co-infection, lesions tend to be atypical. So these ulcers often will become large, and in the old days, a persistent large ulcer was in itself a diagnosis for advanced disease, a definition for advanced disease. The ulcers can also persist, and patients may have lesions that last for months, if not years. And within these lesions, as you try different therapies, the virus can establish resistance, which in itself can become latent. I'll come on to this later. Now, there's a number of guidelines that people refer to. There's the CDC guideline that many parts of the world use. There's the European and the Australian guidelines. What I want to do as I run through treatment is to just show you what this WHO document, this review that was published 2 years ago, has come up with. So this is one of the evidence-based guidelines that it's produced in a range of diseases. For initial infections, the recommendation is 10-day therapy and to use acyclovir 400 milligrams 3 times a day. I've highlighted the cheapest and the cheapest and first-line option. For recurrent disease, acyclovir 400 milligrams 3 times a day for 5 days. This short option of 800 milligrams twice daily or 3 times a day for only 2 days is also possible. Now, with co-infection, with recurrences, they're recommending that we go with the longer dose, with the larger doses only, and for the longer doses only, not to go for this short dose. Now, recurrences of herpes can be frequent, severe, and cause distress. And the recommendation then is that we use acyclovir twice daily at 400 milligrams. In those with HIV, a similar recommendation is also made. So to summarize those guidelines, when you actually have co-infection, the thing to remember is to use full-dose therapy and to avoid ultra-short therapies. Now, these first-line drugs, acyclovir, valacyclovir, and famciclovir, all require thymidine kinase for activation, and that's important to remember when we talk about resistance. Now, there is an Australian study, the FAST study, some of the investigators are actually here, which found that if the CD4 count is restored with antiretrovirals, then standard doses of herpes antivirals can be used. So you don't have to use the longer courses and things. But this WHO guideline has gone for a very conservative approach of recommending 5-day therapies for recurrences. Okay, so the problems we get with co-infection, and I'll quickly go through resistance, the RS problems, rare Hsv complications, pregnancy and transmission. You can actually grow herpes viruses on culture plates where you put the antivirals, these antivirals that we have in. And resistance to these antivirals develops very quickly. But the strains of herpes virus that you get are often of limited pathogenicity. And similarly, in patients, these mutated strains develop very quickly. Now, remember, herpes is cleared by your immune responses. These less pathogenic strains will also be cleared. But in those with co-infection, they may not have the resources within their immune system to clear them, and then these strains become established. These strains can actually get into the nerves and become latent and can recur. Now, the way you manage these is you switch to an alternative agent that doesn't need thymidine kinase or acts directly on DNA polymerase. So drugs like foscarnet, stofovir, pritilovir, imiquimod can be used, and they'll usually work. But the thing is, because these viruses will then establish latency, they will recur, and the next time they recur, these drugs may not work. So usually when you get a resistant strain, it's a warning sign. You've got to do as much as you can to improve the immune status, because the next time it's going to be a bigger problem. Iris-type lesions, even with restoration of the immune system, you can get, with normal CD4 counts, you can get persistent ulcers. And I think many centres have reported cases where nothing has cleared these ulcers. If they're in a bit of the body where there's enough lax skin, you can actually cut these ulcers out and stitch the skin up and hope it heals that way. In the immunocompromised, there are a range of very, very rare and very difficult to manage herpes complications that can occur. And when the immune system fails, it's not surprising that we will see disseminated herpes infections, esophageal and colon-related ulceration. But these days, these tend to be few. They tend to be far between, and we're not tending to see them, certainly where antiretroviral therapies are easily available. There is a debate as to whether we are seeing increased cases of encephalitis or keratitis amongst those with HIV. Certainly for the Hsv Keratitis, there's a suggestion that this is one of the things that our patients get fewer cases of, because it's mostly inflammatory, and you don't get the full range of inflammatory responses in the eye, that it may actually, HIV may preserve our patients from getting this particular problem. Okay, nearly done. Pregnancy, Hsv HIV co-infection. So there's quite a few studies in this area. They show slightly confusing results, but some studies did find higher rates of HIV transmission and adverse pregnancy outcome with co-infection and with the presence of genital ulceration. Now, this is probably only of historical significance in the age of advised universal antiretroviral therapy in pregnancy. That the Hsv effect may be very minor if you can actually provide antiretrovirals. The other practice point to remember, and if your practice is for women with herpes infection to offer them, who are pregnant, to offer them acyclovir in the later stages of pregnancy, is to remember that in HIV positives, there's a tendency to deliver slightly earlier, and so you may want to start acyclovir at 32 weeks rather than waiting to 36 weeks. As I mentioned at the beginning of this talk, the deadly synergy, the links with HIV and Hsv, the transmission is a major problem, and a lot of effort is going into developing vaccines, which have all failed, but also to trying to manage this dynamic, and in controlling herpes to actually control the acquisition and transmission of HIV. Now, I'm sure you're aware that the massive efforts that were put into these studies have not paid off. So consequently, I think we conclude from those studies that this dynamic cannot be exploited at the moment with the drugs that we have. There are stronger drugs that have been developed, but they are riddled with toxicity. Now, these associations you may feel are of historical significance because we now have PrEP to protect our exposed partners and antiretroviral therapy to reduce viral loads in those with HIV. But we've not been able to manage this. The other association that we know about is that co-infection is associated with a higher HIV viral load and a more rapid CD4 decline. But again, with earlier antiretroviral therapy, this may only be of historical significance. There are new drugs out there, but as I mentioned, they are too toxic really to go into general use. So we, at the moment, don't have anything to work with co-infection. So to summarize then, herpes infections can be more troublesome in those with HIV. In advanced HIV, a range of rare and severe complications of herpes are seen. In the absence of effective antiretrovirals for HIV, co-infection is associated with increased rates of HIV transmission and HIV progression, probably now of historical significance. That HIV-related immune reconstitution phenomena are described and can be difficult to manage, and that resistant herpes can be extremely troublesome to manage and requires the underlying immune deficit to be improved as a matter of urgency. Thank you for your attention. Stop there.